I'm going to talk about data, tools, and methods to answer research questions on social determinants of health. As you mentioned, I am Dr. Baker, and I'm associate professor here at UAB in the Department of Sociology. So in this presentation, I'm going to go over three main topics. We're going to go over SDOH concepts and frameworks, SDOH measures and data sources, and SDOH methodological and analytical considerations. So let's start first with concepts and frameworks. Social determinants of health, also known as SDOH. This term has become ubiquitous. And to kind of give you an example of that, you see a little table that tells you the year and how many papers were cited using this term. So in 2005, there were 26 papers on PubMed that used the term social determinants of health. But by 2022, there were over 4,000. So there has been a 160-time increase in SDOH papers over the last 16 years. And to give you kind of a idea of what's being published, I have some headlines and journal article titles as well. And as much as it's become ubiquitous, it has become equally pervasive in its misuse. And that's because you really need a framework, a conceptual framework when you're talking about social determinants of health. There is not a social determinant of health, but rather it is made up of a bunch of different things. In response to this, the NIH in 2022 established the Research Coordinating Committee. And this was done out of the urgent need to develop a coordinated strategy to propel discoveries to improve individual and population health, reduce health disparities, and advance health equity. SDOH conceptualizations, like I mentioned, there's not just one factor, but rather these are the conditions in which people are born, grow, live, work, and age. And also the wider set of structural factors shaping the conditions of daily life. So this is a framework. This is the WHO framework. These social, economic, and legal forces, systems, and policies then impact opportunities for jobs, education, housing. These are our structural determinants of health, so they are not at the closer end of health. And then these things impact our intermediate factors. So these include things like your built environment, the living and working conditions that you're in. And this is also where you can get some geospatial determinants of health. And I'm going to talk a lot more about those as well. The basic tenets of NIH SDOH conceptualization. There's 6 of them. The first is that SDOH can improve, maintain, or hinder health. And there are multiple direct, indirect, and interacting pathways that this happens through. I'm going to talk a little bit more about that when I get to the conceptual model as well. SDOH interact with biological, psychological, behavioral, chemical, and other environmental factors to promote or compromise health. And SDOH influences family and individual level, social and economic characteristic or economic circumstances. To give you an idea of that, I have a little pyramid demonstrating this. We have our social determinants of health, the circumstances in which people are born, grow, live, work, and age. So some examples of this include employment. When these are unfavorable, they become social risk factors. So from employment, we would have things like unemployment or low-income jobs. And when these are prioritized by individuals in the context of healthcare, they become social needs. So the social determinants of health lead to social risk factors, and then according to the individual, they become social needs. And SDOH can have different health consequences within and across populations. And this is largely due to differences in exposure or susceptibility. So I'm going to talk a lot about geographical measures, but also individual level measures of SDOH oftentimes do not impact the same group the same way. We tend to find that for non-Hispanic whites, a lot of SDOH factors have a larger impact than they do for non-Hispanic Blacks or Hispanics. Why might that be the case? Structural factors such as racism, sexism, homophobia, or classism determine if the conditions of daily life are unfairly distributed. Inequitable allocations of power and resources manifest in unequal exposure. And then finally, addressing SDOH is relevant to population, community, and individual level health. So why do you need these frameworks? These frameworks are important because they help decide what, why, and how to measure in order to answer your research question. So we went over a little bit about the WHO social determinants of health. There's also the health equity measurement framework, as well as the heuristic framework of SDOH mechanisms. And the NIMHD, so many acronyms in this presentation, also has a research framework as well. So this table actually came from a grant that I submitted with my co-director, Gabriella Oates, where we have our different domains on the side and levels of influence at the top to kind of give you guys an idea of where we see these different things impacting people. So you have individual level measures that are related to biology, such as sex, age, genotype, clinical characteristics, or even things like stress markers. You have things related to the sociocultural environment. This could be race, ethnicity, education, employment, and income. Though I do want to point out, depending on what your research question is, sex and gender might actually fit under that. And these can go all the way up to the societal level, where things like social vulnerability index or the child opportunity index are impacting health. So we go from the individual to the interpersonal, community, and the societal. And this can help you think about where do you think these things are impacting health outcomes. That was a little bit about concepts and frameworks. Now I want to go over SDOH measures and data sources. So there's individual level measures of SDOH as well as these geographical or neighborhood level measures of SDOH that I'm going to talk about. Some individual level measures, they can go across multiple domains. So these are just a few of them, and there's a lot more. These can be things like income, discrimination, health literacy, health insurance. What makes it individual is it's asked to the individual. These are your own reports of your income, employment, or discrimination. And as far as variables go, there are multiple variables for each one of these domains, literally hundreds. And depending on what your research question is, that should steer you on which one of these would be the most important. Where can you get some of these data sources? Survey data. I work a lot in big national data sets. Those oftentimes have these individual level measures of health. However, if you're looking at electronic health record or electronic medical record data, there's social screening in healthcare settings. And so this is done a little bit, but not that often. So yes, we do have these psychometric screening tools and social risk screening tools, but oftentimes they're not implemented or they're not implemented evenly across the board. If you've ever looked at electronic medical record data and looked at some of these factors, you'll notice that people that they think these factors impact are the ones being asked. So if they think someone's homeless, you'll find a ICD-10 code, an ICD-10 code for homeless. But if you don't present as if you have these issues, they tend to be missing on the electronic medical record data. Though there is a big change to move this, though, using, I believe, REDCap to collect more systematic information about social needs in electronic medical record data. There are two resources for individual level measures that I'm going to go over. And this would be if you were collecting data and wanted to include individual level measures of SDOH. I work a lot in secondary data, so oftentimes I'm seeing what people collected and then how I can use it. But if you are collecting your own data, then this is a really great time to include some of these individual level measures of SDOH. So the first one I'm going to go over is the Phoenix Toolkit. This is a web-based NIH catalog of recommended SDOH measurement protocols. If you are submitting an NIH grant, they really love it if you use it. It has the social determinants of health collection. And within that, there's the core collection as well as two specialty collections. So the core collection has 16 protocols. So these are the different ways that you could ask age, education, income, or health literacy. They're literally the measures, as well as give you the way that you would score them afterwards. And then the two specialty collections, they include more individual level SDOH measures, such as wealth, access to health technology, health numeracy, discrimination, as well as structural SDOH measures, also what I call neighborhood level measures. And these can include things like the social vulnerability index, air quality index, environmental justice screening, residential segregation, etc. So for the structural SDOH measures on Phoenix Toolkit, they'll tell you where to go to find these. For the individual level measures, they'll actually give you what you could stick in your survey yourself. There's also the UAB SDOH Toolkit, and unfortunately, it is currently under construction right now. It used to be housed on Canvas, which is what you see right here, but we're actually moving it to a website, so it's a lot easier to access. And this kind of complements Phoenix. Admittedly, I started this before Phoenix came out, and so I've added to it and supplemented it to make it more complementary to Phoenix. So the UAB has some measures not included in Phoenix, as well as Phoenix has some measures not included in it. Also, the SDOH toolkit, our UAB toolkit, has a little bit more information on it. So who are these populations? Who is this validated for? As well as some research on what have people done with it. And also a nice little write-up that I did. So if you like them, please let me know, of each of these different domains. So once again, those are more individual level measures. I'm going to talk now about some area level measures. So what are your area level measures? These are population data aggregated to a small geographic unit, oftentimes the block group or the census tract. These come from the US Census, the American Community Survey, which is actually the US Census and replaced the long form, I believe, in 2000. And other governmental agencies such as USDA, EPA, the Forest Service has a tree canopy database. And when would you want to use these measures? One, as a proxy for patient level or individual level SDOH measures when they're not available, because once again, electronic medical record data doesn't have a lot of those beyond marital status on there. So if you don't have any individual level measures, these work not as good, but at least it's better than not having anything, right? At least you're taking some of these measures into account. But if you have both individual and area level measures, then you can assess independent neighborhood effects, right? So are these neighborhood level measures impacting your outcome because poor, less educated people are more likely to live in neighborhoods that are poor and have less educated populations? Or is there something actually about the neighborhood or environment that's impacting your health above and beyond some of these individual level measures? So having both of them is always way cooler, in my opinion. So what are some of these measures? These can involve single variables, and there's a very long list of them right here. A lot of these come from the ACS, the American Community Survey. And you could include these as measures in your models. However, I would argue that oftentimes you're probably going to be better off with a composite indices. So these are ones that have been created for this use. There's the area deprivation index. This has 17 ACS variables in it, and it is measured at the census block group. And I'll go over exactly what that means a little bit later. The social vulnerability index also uses ACS variables. It is measured at the census tract level. And about I think seven of the variables between ADI and SVI overlap. Which one you'd want to use is largely going to depend on your research question. There's the Child Opportunity Index, Environmental Justice Index, Social Vulnerability Index, Child Opportunity Index, and the EGI all have subscales within them. So it gives you one overall measure as well as some subscale measures. So EGI, for example, gives you information about the socioeconomic characteristics as well as the health characteristics of the neighborhood, as well as exposure to environmental pollution. The reason I pointed that out is because the EGI actually uses the SVI as its measure of socioeconomic deprivation or socioeconomic characteristics. And so does the Child Opportunity Index. There's also many others, including food access, walkability, residential segregation, and crime as well. Where can you get this area level data? Like I mentioned, if you go to Phoenix Toolkit and it's listed there, they'll actually take you directly to the website that you would need to get it from. You can also get them from the US Census Bureau. If you're interested in using the American Community Survey, there is a tidy census package that you can use with R that I would strongly, strongly recommend. I'm not the most proficient R user, but I absolutely love it. It makes it very easy to use and pull data from. You also have measures from the CDC. This is where we get our SVI, as well as some of these other measures, such as CDC Places. CDC Places is very cool. It's part of the EGI, and it lets you know about the health on a census tract level. So what does high blood pressure look like? What does obesity look like? Respiratory issues, lack of health insurance. We also have the US Department of Agriculture. This is where you can get your LILA measure, your low income, low access, also known as a food desert. EPA has some as well. This where we get our National Walkability Index as well as green space. Health Resources and Service Administration. They actually create a medically underserved area. So at the census tract level, are you in a medically underserved area? National Land Coverage Database. So this is green and blue spaces available to you and how developed they are. And then there's some repositories as well. So AHRQ has a lot of the measures actually that I've mentioned within it. So if you go to the AHRQ, you can find a lot of these other measures such as LILA and SVI. So if you have area level measures, now you need to figure out how you're going to get them on people. And to do this, you need to link area level SDOH to the clinical data. How do you do this? First, you obtain location based on residential addresses. So you get whatever someone's address is. And then using GIS, you assign a geo identifier. Oftentimes, this is Federal Income Processing Standards, also known as FIPS codes, to each address. And then you just download the SDOH database. That's going to have a FIPS code associated with it. And then that you have your FIPS code from the SDOH database, as well as your FIPS code from your clinical data. And that is how you can merge them together. A little bit more about geocoding, because I think this is actually very interesting. Geocoding literally means the process of converting textual information into geographic coordinates using a GIS or Geographical Information System or GIS. So how do they do this? They take your addresses that you would have listed in an Excel file or a CSV file, and then you put it into a GIS geocoder, and it makes it a latitude and longitude. And then you have it on a map. You bring in another layer, which is the boundaries for your census tracts, or the boundaries for your counties, or the boundaries for your block group. And then any dots within those boundaries are assigned that FIPS ID. So that's literally how geocoding works. You get this latitude and longitude, and then from that latitude and longitude, you have to layer on another thing to figure out where the boundaries are and if people are in those boundaries. I'm going to take this moment to mention geocoding practicalities and especially concerns. So if you use any of these web-based geocoding options, there's one through R, there's one through SAS, there's one through Bing and Google even. That means that you could potentially, or you're not could, you are actually putting that PHI, that private health information, out to the web. So you are not complying with HIPAA privacy rules. Whenever you use any of these web-based, online, cloud-based geocoding services, you're exposing PHI to the internet. And addresses are PHI. So you don't necessarily want to use any of these. What you want to use is geocoding internally behind a UAB firewall. So in Boshell, we have a computer that has Google Street Maps Premium on there, which is what you would use in order to figure out the boundaries of your people. so that you never actually introduce any of your information to the internet. So it's a computer that you just is all internal and protects PHI. Another reason why you might want to be careful is accuracy can vary widely, and it can vary widely depending on a number of different factors. First is how clean is the data, and what format is it in? What geocoding technique will be used? There's a couple of different geocoding techniques that you can use, such as complete matches versus ties, or exact address versus places. And then what geocoding strategy best suits your study needs, as well as what year reference data are you using. So what is US Census geographies? I love US Census geographies because they're nested inside each other and they're perfect. And that the sense that there's no overlap or hanging out. So you have the nation, and then from the nation you have region, and then from regions you have your states. States go to counties, counties go to census tracts, and census tracts go to block groups. So they're nested within each other. And I'll talk about zip codes or zip codes in just a minute. I'm supposed to stay over here. But you have your counties, and then within your counties you have your nested census tract, and then within your nested census tract you have your block groups. Blocks is another area level measure that you can use, but most of these indices that I've talked about, as well as those single level variables, aren't measured at the block level. So a small area geographies, because these tend to be the ones that people are interested. The smaller, the better, in my opinion, because it's a better accurate representation of your more immediate neighborhood. And I'm going to talk about census tracts versus block groups. This is actually in Birmingham. We have our census tract broken up into these different block groups. And what does this mean is that they have different population thresholds. So census tracts are bigger. The optimum population threshold is 4,000, whereas block groups are smaller. We don't actually have an optimum in 2010, but rather block group population ranges from 600 to 3,000. So block groups are a smaller geographical unit than census tract and are nested within them. All right, so now I'm going to talk about zip codes. And I've never before been so passionate about zip codes in my life because zip codes are not fun to work with. So if you have actual addresses, definitely use actual addresses. Zip codes are really, really imperfect. Zip codes aren't even actually a polygon, rather they are a postal service route. So in order to make a zip code a polygon, we convert them into ZICDAs. And ZICDAs are the zip code tabulation area. And to kind of give you an idea of what that means, I have 2 zip codes here as well as a ZICDA. So the blue outline is the ZICDA 35207. And then we have green, which is another zip code. I'm going to move my little guy right here. 35068. And then we have purple, which is another zip code. So you can see that the ZICDA actually has 2 zip codes in it right now, right? It has all of 35207 and then a little bit of 35068. So in order to use zip codes, you always have to transfer them into ZICDAs. So that was zip codes versus ZICDAs. But now that you have a ZICDA, oftentimes what you want to do is convert it to a census tract. So any of those SDOH measures that I've mentioned are oftentimes measured at the census tract. If they're measured at the census tract, you're going to have to aggregate it up to get to your zip code level measures. In order to do that, you have to use a crosswalk. And that's because within this ZICDA 35207, you see you have 4 different census tracts. And for example, one of those census tracts is almost entirely in it. Funny enough, none of them actually are. But different proportions of each census tract is related within this ZICDA. So you would have to use a crosswalk to figure out how much of that ZICDA or how much of that census tract is in that ZICDA and how many census tracts are in the ZICDA. And if you can just, once again, if you have the addresses, so much easier, and then you don't have to go through this zip code route. However, I do know that sometimes zip codes are easier to get than residential addresses. And if that's all you got, then zip codes are better than nothing. And there are definitely crosswalks out there to help you do this. So Now we've talked about zip codes. I'm going to talk a little bit about US Census geographies. So I mentioned that the reference year is really important. What year was your data collected? And that's because you want to tie it to the appropriate census. Every 10-year census geographies change. So because of that, I need to know which census geographies you want tied on there. So for example, we have Birmingham in 2010. We have 2 census tracts. And then in 2020, they broke down those 2 census tracts into 4 different census tracts. So you would need to know which vintage is the correct term, which vintage you would want to merge your data onto. Also, you do need to keep in mind what census geography is the SDOH measure that you're interested in using. So if the measure was made between 2010 to 2019, it's probably using the 2010 vintage. If it's 2020 or onward, you might be using the 2020 vintage. And you'll have about 30% of your, or well, actually 65% of your cases won't match if you're using the wrong geography. And for the most part, we tend to break down bigger census tracts into smaller census tracts. And by bigger, I mean bigger population. I do want to take this moment to plug the GIS technology on campus. So if you are not aware, ArcPro, or ArcGIS Online, and all other Esri desktop, mobile, and cloud-based geospatial technologies are freely available for any faculty or staff at UAB. So if you're at all interested in this, I strongly encourage you to download Esri or ArcGIS and kind of play around in it. It's honestly pretty easy to use. There's a lot of online learning modules to use it. They have curated learning platforms that offer a sequenced way of learning specific content and skills via reading, videos, and hands-on resources. And these learning paths are tailored to your individual needs. If you do want it, you can't just go to the IT webpage, but you have to email Arian Nassal, and she will actually give you the link in order to be able to access it. You're going to have your own username and password in order to access any of the ArcGIS online stuff. But definitely, if you're interested, like I said, please email her and she will get you connected. That was a little bit about SDOH measures and data sources. Now I want to talk a little bit about SDOH methodological and analytical considerations. To begin with, I just want to start off with this conceptual model. And a conceptual model, a little different than a framework, but this will tell you how, why, and what to control for, and also not to control for, and how to make causal claims. When you're interested in SDOH measures, these things are oftentimes connected to each other. So if you over control for it, you'll think that nothing happened. So if you think that, social class is related to heart failure, and you've controlled for things like individual level income, obesity, smoking, a whole bunch of other clinical covariates, you might find that social class has no impact on your outcome, but that's really just because you've over controlled for it, right? So if you put something that's on that causal pathway, then you're going to lose it. Oftentimes too, some of our SDOH measures tend to impact things that are not as further down on the causal chains. So example, like heart failure. Heart failure is very much related to social class, and social class is relating to smoking and obesity. So it might be more informative to look at social class to smoking and obesity rather than social class to heart failure. Once again, if you put all those things in a model, you might find that social class has no impact. But once again, it's probably because you're over controlling for it. If you're interested in how, for example, racial disparities in health are explained by social determinants of health, you would need a model that had both race ethnicity and a model that had race ethnicity as well as the social determinants of health. The mediation is really key there. Some more methodological considerations. You want to know what year your data was collected. And this can become incredibly difficult if you have longitudinal data versus cross-sectional data. And the reason you want to know what year your data is collected is to connect it to the right census vintage, right? Do you need 2010 or 2020 geographies? And the other reason you want to know is because a bunch of these indices are renewed, right? So for ADI, we have an ADI for 2010, an ADI for 2013, 2015, 2019, 2020, and 2021. And depending on when your data was collected, you would probably want to use the version of ADI that most closely matched the year that you asked the people their addresses. The timing of measures, exposure should be measured prior to the outcome. So you want to know their address prior to knowing their health outcome. Sequentially, you want to make sure it happened beforehand. This can become, if you don't have it beforehand, it's not the worst thing to get in the world to go back and get it retrospectively. You just have to be aware of sort of the limitations that involves, and also be aware of like what that means for your research question. If your research question was about mortality, you wouldn't want to go back and ask people their addresses because they're not there. So just, be cognizant of how you're collecting this information impacts your outcome. You also have people that change addresses. So you want to know when you took your address in relation to when you're looking at your outcome. I'm going to go over a couple of analytical considerations when you're using some of these area level SDOH measures. And this is really particular to those area level SDOH measures. These are linear model assumptions. I'm not going to go through all of them, but I'm going to go over a couple of them that I think are super important when we're looking at area level SDOH measures. And why is this important is because area level SDOH measures are nested data. So you have people living in the same community. Another example of nested data is time series data, where you have multiple observations from that same person. The data is nested inside another structure. This can cause issues because you have dependency between observations, and ignoring this dependency can lead to incorrect results and underestimate standard errors. So people that live around you are far better predictors of your health than people that live further away. Could also have multicollinarity issues, which can make it difficult to isolate the unique effects of individual predictors. If you put all 17 predictors from ACS or from the ADI in a model, you would probably end up with multicollinarity issues. You have autocorrelation and endogeny issues. So autocorrelation or serial correlation, this largely applies more to time series data, but it is when the residuals are correlated with each other over time and across observations. So you are a very good predictor of your future behaviors. And then no endogeneity. This one always actually cracks me up because in sociology, we never actually accomplish this. The independent variables should not be correlated with the error term. Endogeneity can lead to biased coefficients, estimates, and incorrect inferences. So what are the solutions that you can use? The more complex statistical models that reflect complex random effect structures. So I'm going to go over generalized linear mixed models, generalized estimating equations, and then robust standard errors with regression. And I've listed them in what I think is the easiest way to implement them. So GLMM are the hardest, regression standard or robust standard errors with regression are the easiest. Minimum adjustment is required. And which one you're using really depends on the nature of your research question as well as your data. So your research question. So these models can answer two very different questions. One, do area level measures impact your outcome of interest, accounting for this fact that you have correlation in your errors? This tends to be the most common use, right? So I'm just interested in whether or not living in a food desert impacts your frailty when you have GI cancer. And the second way that you can use some of these models is, does variation in the individual level characteristics explain geographical variation in your outcome? And I listed it as uncommon, not because I think it's uncommon, it's just the least common thing that I've heard other people want. Why is that? Because it requires a lot of geographical areas. The number of geographical areas is approximately your sample size, and you also want a decent number of observations within those geographical areas. So this one tends to require a little bit more data. You would want to use GLMM models if your outcome is continuous. If you have longitudinal data, One of the great things about GLM models is you can have multiple levels of nesting. So you can have observations nested in an individual and then people nested in a community. Or you are interested in explaining that geographical variation with individual characteristics, but like I said, that's a little less common for people to do. So what would you do if you wanted to include to use GLM models? You would include a random intercept at the geographical unit of clustering, for example, the census tract, and which geographical unit of clustering you're using depends on which SDOH measure you've included. So LILA, SVI are measured at the census tract, ADI or area deprivation index, walkability are measured at the block group. If there is not significant variation in your random intercept, then you can use robust standard errors with regression or GEE, generalized estimating equations. You're not really getting a benefit for this more complicated modeling strategy, right? So if there is no individual level variation in the effect of these intercepts, then that's saying that the impact of that SDOH measure is relatively the same across the people that live in that area. Give you an example using GLM. This is UAB EHR data on everyone with COPD diagnosis between 2010 and 2020. This involves two levels of nesting. We have geographical as well as time series. And we have random measures at these, we have an intercept at the census tract level, an intercept at the individual level, and a slope at the individual level. And if you remember early on, I said that oftentimes SDOH measures don't impact different populations the same. You can definitely see this here. So whites are in orange and blacks are in blue. And you'll notice that a lot of these SDOH measures have a much larger impact on whites than they do for non-Hispanic blacks. Generalized estimating equations. This has multiple linked functions to allow for the different nature of your outcome. So general linear mixed models, you're going to want a linear model. But maybe you don't have a linear model. Maybe you have an ordinal or categorical or count model. GEE models accommodate these very nicely. However, you would want to use this if the clustering is more of a nuisance than of interest. GLM models are the ones that allow you to see if some of that geographical variation is due to that individual level characteristics. This is really, I'm just interested in, do those geographical measures impact my outcome of interest? And then if you have very few observations per cluster and encounter convergence issues, then you probably want to use regression with robust standard errors. To give you just a little example of GE, this is frailty and food access. So this is the UAB care registry. People were enrolled between 2017 and 2023. The outcome is the risk of frailty. And it is measured at one point in time. So this is only nested geographically. When you also use GEE models, you need to specify the correlation matrix. Unstructured tends to be the best, especially if you have relatively few observations per cluster. So this was a paper that was recently published with Mackenzie Fowler. I think it'll be in this part, no. Okay. But we're looking at food access. We have model 1, which includes age, race, ethnicity, sex, cancer type, cancer stage, as well as our measure of LILA. And then we have that second measure or second model that adjusts for those individual level SDOH measures. So the second model includes education and marital status. And even though you shouldn't compare odds ratios across models, I'm going to do it anyways. You can see that the odds ratio gets smaller after you account for some of those individual level measures. Yet they still remain significant. And then finally, regression with robust standard errors. You want at least 20 to 50 clusters when you're going to use this. If you don't have an adequate number of clusters, then you can't really examine how variation in cluster level factors impact your outcome. So you just need more clusters. And it doesn't really matter how many observations per cluster you have. The other two really get a little finicky if you don't have very many observations per clusters. And really, general linear mixed models, you're going to want more than less. And then just to tell you guys a little bit more about my SDOH core, we are an institutional research core. We provide a bunch of different services. We also have free consultations, so come and talk to us. We have drop-in clinic hours on Friday from 9:30 to 11 in Beauchelle. It's literally just me unless anyone wants to come and say hi. So if you want to come talk about your project, I'm there just in the conference room on the 8th floor of Bushell. And the SUH team includes me as well as Gabriella Oates, Arian Nassal, who is our health geographer, Lucia Juarez, who helps with data analyzing, and Joy Lavina is our most recent hire, and she is helping with project management. So if you've contacted us within the last month before break and we didn't respond, that's because we just got Joy and we were a little inundated. So reach back out to us if we haven't responded yet.